Hello and welcome to the Malaria Notebook with me, Liliana Dayo. Today we learn about understanding malaria in pregnancy, insights and interventions. Welcome. So what's malaria in pregnancy? Malaria in pregnancy occurs when a pregnant woman becomes infected with the Plasmodium parasite, usually Plasmodium falciparum in the case of Africa. Malaria in pregnancy is considered a public health priority because it's common in endemic areas and highly dangerous to both the pregnant woman and the unborn child. So what are some of the malaria in pregnancy complications? In addition to the complications in the ordinary people, malaria in pregnancy can result into placenta malaria, maternal anemia, where the pregnant woman presents with a hemoglobin level of less than 11 grams per deciliter, miscarriage, where the pregnant woman can lose the pregnancy before 20 weeks gestation, intrauterine growth retardation, where the unborn child does not attain the weight as per the gestational age, stillbirth, where the pregnant woman loses the pregnancy after 28 weeks, low birth weight, and premature delivery, amongst other complications. Scientists have identified some preventive interventions that, when used appropriately, can prevent malaria in pregnancy. And this includes intermittent preventive treatment in pregnancy with sulfadoxine pyrimethamine tablets, use of insecticide-treated nets, prompt diagnosis and effective treatment of malaria, and health education and counseling, where the pregnant woman and community members are given messages that will enable them embrace the malaria control interventions. So about intermittent preventive treatment in pregnancy with sulfadoxine pyrimethamine, commonly referred to as IPTp-SP, the World Health Organization recommends the use of at least 3 doses of SP during a pregnant woman's journey. The average uptake of SP in sub-Saharan Africa is said to be suboptimal, with some researchers putting it at approximately 30%. The uptake ranges widely from slightly above 20% in Uganda to 60% in Ghana. Some of the missed opportunities include delayed antenatal clinic attendance, erratic supply of sulfadoxine pyrimethamine, and misinformation, mostly influenced by cultural practices and beliefs. There are national targets which have been set up by different countries. For instance, Kenya has put the optimal target to be at 80%, whereas in Ghana it's at 85%. But all the same, all these targets have not still been met. So a study that was done a few years ago by Sani et al. Demonstrates still low uptake of IPTp3 amongst some of the African countries. And as you can see on the slide, in Ghana, it's put at 61%, Kenya 37%, Burkina Faso 22%. And this was following the malaria indicator surveys that were done in the different countries in 2018. So the use of insecticide-treated nets has proven to be one of the ways that can protect pregnant women from getting malaria. ITNs are mosquito nets which are impregnated with chemicals that can either kill or repel the mosquitoes, and sleeping under the ITN every night can protect the pregnant woman from getting malaria. Some countries provide it for free in the antenatal clinic, whereas there are some which issue them at a subsidized cost. There are studies which have demonstrated that many women, pregnant women and children below the age of 1 year have been saved from getting malaria through proper use of the ITNs. About prompt diagnosis and effective treatment of malaria in pregnancy, any woman that presents with fever and lives in a high malaria transmission zone or has history of travel to a high malaria transmission zone needs to be tested and treated for malaria promptly. Most parts of Africa tend to use either the rapid diagnostic test kits for malaria or microscopy, but also there are other advanced technologies that can be used for testing malaria. Prompt treatment with safe, effective antimalarial drugs as per the national guidelines is also key. And it's important for us to know that early treatment reduces the risk of severe diseases, maternal complications, and poor birth outcomes. Also important, it's necessary for us all to ensure that all the healthcare workers who deal with pregnant women are trained regularly on the importance of malaria prevention and how to treat pregnant women when they present with signs and symptoms of malaria. On health education and counseling, it is important that we encourage early and regular antenatal care visits by the pregnant women. Also, educate pregnant women and families about some of the malaria risks and how we can prevent the pregnant women from experiencing these complications. Then also having experience of high cultural beliefs and practices, it's important as healthcare workers that we are able to address the myths and misconceptions surrounding some of these malaria control interventions that will protect pregnant women from getting malaria. Then also in health education and counseling, we need to promote consistent use of ITNs and adherence to the IPTp schedules. And lastly, we need to engage the community healthcare workers to be able to identify these pregnant women early in their gestation and encourage them to attend the antenatal clinics for SP, amongst other malaria control interventions that will protect them from getting malaria during their pregnancy. Questions and ideas. How can we improve awareness about malaria in pregnancy in our community? How can we support pregnant women to complete IPTp doses? And how can communities help increase the uptake of ITN use amongst pregnant women? So our take-home message for today is that protecting pregnant women from malaria means protecting two lives, that of the pregnant woman as a mother and the unborn child. Proven affordable interventions like the use of IPTp, SP, and ITNs can save a life. Early care, prompt treatment, and community support are key, and together we can reduce malaria and build healthier futures. Thank you for listening. Subscribe to the Malaria Notebook for more lessons. Let's fight malaria one lesson at a time.